Good morning, everyone. My name is Judy Abrams, and I am a past president of the Ovarian Cancer National Alliance. 17 years ago, I lost my best friend, Judy Mello, to ovarian cancer. To honor both Judy Mello and our friendship, her husband, Jay Schwam, established the Mello-Abrams Annual Lectureship, which supports our ability to invite leading authorities in the field of ovarian cancer to address this conference. Judy was first diagnosed with ovarian cancer in 1994, after having been diagnosed with breast cancer in 1986. She lived her life fully and courageously, without despair, and always looking forward, never back. She was also sustained by the love, affection, and support of her family and her many friends. But what allowed her to live her life as fully as she did was the incredibly positive attitude that she had until the very day she died. She lived each and every day guided by that spirit that she preached to one and all. Every day is a beautiful day. It's only the weather that changes. I use that now too. I am excited to introduce this year's Mello-Abrams Lecture, What's New in Ovarian Cancer Research, Treatment, and Survivorship, sponsored by Genentech. Renowned ovarian cancer expert, Dr. Stephanie Blank, will discuss what's new and on the horizon for the treatment of ovarian cancer. Dr. Blank is a director of Gynecologic Oncology for the Mount Sinai Health System and a professor in the Department of Obstetrics, Gynecology, and Reproductive Science at the Icahn School of Medicine of Mount Sinai. It's a great pleasure for me to introduce Dr. Blank.
My name is Stephanie Blank, and I am the Director of Gynecologic Oncology for the Mount Sinai Health System. I'm also a professor at the Icahn School of Medicine at Mount Sinai, Associate Director of the Tisch Cancer Institute at Mount Sinai with a focus on women's cancers, and the current SGO president. And I so appreciate being asked here today to give this talk. These are my disclosures. As I mentioned, it's a great honor to be here. And to me, I'm really speaking to the most important audience that there is. And I felt this way for a really long time. So when I was first starting out, a long time ago, newly minted, 20 years ago this is, I would put on these ovarian cancer survivor courses. Maybe even somebody listening to this talk might have been to one or two of these along the way. And I met a lot of great people along the way. But while I was planning one of the very first ones, I needed to get somebody with a longer term or sort of historical perspective to explain how much better it was at that time for people with ovarian cancer than it had been previously. And I remember trying to get the like one of the oldest people that I know, and oldest gynoncs that I know, and which was, the talk actually was quite dramatic and moving. And now, to me, it's a bit ironic that 20 years later, I am that old guy. And I've been asked to talk here, as I said, about what's new in the field, and I'm really excited to share this with you. To me, this photo is the promise of a new day, the future, which is fitting for this talk and for the theme of this conference, Uniting for Hope. And I apologize for starting with a graph, and I'm only going to have like 3 more slides with these, I promise. But for some reason, I really wanted hard evidence to begin and for my first point. So don't be fooled by the downtrend here. This is a graph we really want to be going in the downward direction. This is looking in the top. This is the incidence of ovarian cancer, and bottom is the deaths from ovarian cancer. And you can note that both of these are going down, and this is great. And they have both been consistently decreasing for years, but actually the slopes are getting steeper, which is a good thing. The rates are down about 3.3% per year for incidence, and deaths are down 2.3 per year. And what's actually happening is people are living longer with ovarian cancer, and there are more people living with ovarian cancer than ever before. So why the decreased incidence? This is mainly due to a couple of things. One is oral contraceptives, birth control pills, which decrease the risk of ovarian cancer. Another is something called opportunistic salpingectomy, which I'll speak to you momentarily about. And then thirdly, it's because we can identify people at increased genetic risk for ovarian cancer and perform risk-reducing surgery, and that very much diminishes the risks of ovarian cancer. Now, why are people living longer? People are living longer because we have better therapy for recurrent disease. We have more options, and people are also living longer once they progress. So overall, things are shiny and bright. Now I'm going to continue along this line. I am an optimist by nature, so I apologize if you are not. So the truth is, we've really learned a lot along the way. We can answer questions about ovarian cancer that we never could before, and I'll be addressing these in a different order, actually. And before we actually begin, the very first question is that what is this? It is actually not ovarian cancer, some of it. We believe that the most common subtype of ovarian cancer is actually tubal cancer. And this picture on your left basically sort of gives you a picture of how this works. The cancer is brewing in the tube and it sprinkles onto the ovary, but it actually started in the tube. And the reason that we learned this is for a couple of things. First, we identified this in the surgeries that we did for people with BRCA1 and 2 mutations. We found very early cancers in the tube. We've always known, or actually we've known for a while, I'll say, that both tubal ligation and hysterectomy are preventative against ovarian cancer. And then after we had these theories, our pathologists started processing all the tissue in the lab quite differently, looking at the tube more closely, and they actually found precancers in the tubes in a lot of the things that we would have looked at as ovarian cancer. And, you know, in my institution, we went back and looked at it, and actually a lot of the things that had previously been called ovarian cancer were actually tubal cancer. So I'm going to say ovarian cancer throughout, but remember, it's tubal cancer. So let's start here. In 2016, the National Academy of Medicine convened a panel of experts and issued this report, Evolving Paradigms in Research and Care for Ovarian Cancer. And it's a curious color choice, given that teal seems like it would be very obvious. But here in this report, which is very long, and it's actually fantastic that such, you know, that the National Academy had interest like this in this in this condition. But they talked about the biggest opportunities in ovarian cancer, and I'll stop putting quotes around ovarian as we go. But specifically, we wanted to focus on research, focusing on specific disease subtypes, and increased focus on precision medicine, improved understanding of genetic and non-genetic risk factors, screening and early detection, consistency in the delivery of standard of care, as well as increased attention to survivorship issues, including supportive care with long-term management of active disease. So first, let's start with subtypes. This figure was used everywhere right after the report came out. And what it's trying to say is that ovarian cancer is not one entity. We used to treat everybody the same. And again, this report emphasized that there are many different subtypes. So on the left here, they're basically subtyping it out. And all of these subtypes are based on, if you will, where the tissue looks like it came from in the female gynecologic tract. And, you know, it's based on histology. So the most common subtype is called high-grade serous. And this is the one that I just mentioned to you that comes from the tube. But there's also a type called low-grade serous, which even though they both are serous, they're very, very different. There's also some that arise in endometriosis, and these are called clear cell and endometrioid carcinoma. And then there's a mucinous subtype that we don't know all that much about. So we made we decided that we should not be treating all of these the same way. And this on your right is sort of a distribution of these different types of histology. So again, 70 to 74% of them are high-grade serous. And I do speak about that a lot, but there are other subtypes, and we do need to look at them individually. And then when we learned a bit more, it's not only that these are all different by how they look under the microscope, but they're different on a molecular level. So this is a breakdown in terms of the sequencing of different people with ovarian cancer. And this is a breakdown of all the different mutations that are associated with ovarian cancer. So they're not, you can't really treat all of them the same way because they don't all work the same way. So again, ovarian cancer is a spectrum of conditions. And what that really means, I'm sorry to repeat myself, but one size in ovarian cancer does not fit all. We need to find the right patient, the right drug at the right time, and that's absolutely not the same for everybody. The good news is, once we have the diagnosis, we have so many more tools to treat it. And so just look at this timeline. It is super exciting. So across this axis, it shows the dates at which the FDA approved new treatments for ovarian cancer. And you can see it's heavily weighted to the right, the here and the now. So everything before 2010 was a form of chemotherapy. And since then, all treatments have been targeted agents. And these were completely different than chemotherapy. They more like mess up the inside of how the workings of the cancer cell is rather than killing everything. And so these new forms of drugs are on this timeline, and there are many more that are not yet on this timeline, but hopefully will be soon. But these include anti-angiogenics, bevacizumab, as well. These drugs work by interfering with the tumor's ability to form blood vessels and basically starving the cells. We also have PARP inhibitors, which I'll speak about momentarily, as well as immunotherapy for selected patients. And just to hammer this down and to say it again, there have been more approvals since 2014 than there were in the prior 60 years combined. Stop for a minute and think about the enormity of this progress. So we are truly in the golden age, the renaissance, if you will, of care for people with ovarian cancer. And so much is happening. There's progress, advancement, and hope. And this is absolutely not to say that we're at the top and it's all downhill from here. I just feel we will look back and say, wow, that was when it all started. So how did this happen? It's really by people working together. And some of the main things I think that have really pushed the field forward include research funding, clinical trials, and education. And while, before I get back to the rest of my talk, I really wanted to give a shout out to the Ovarian Cancer Research Alliance for really promoting all of these things. They have a huge impact looking at research, education, advocacy. If you go back and look at grant awardees, for example, for OCRA and other, so the Foundation for Women's Cancer, you'll see current giants in the field when they were just junior people and the story of why and how we have made this progress. So back to treatment. So this is a version of a treatment paradigm for ovarian cancer at present. And the thing that's important here is that there are a number of changes that have happened over the past couple of years that make this different from how it was before. These are big paradigm shifts. So one is the concept, once somebody is diagnosed, we used to start everybody with surgery, but now we know that there are certain patients that should start with chemotherapy. They will do better. So that's a big change. And so the timing of chemotherapy is different. We have the possibility of adding different agents with our chemotherapy, the bevacizumab we mentioned before, and that may work better for certain patients. We don't do surgery at the end of chemotherapy, which used to be done. We have this concept of maintenance, a drug that you take to sort of, solidify the response that you have obtained, and I'll talk about that, of course, more. We have, even when you get treated, if you have a recurrence, there's maintenance at that point as well. The role of secondary surgery has been significantly questioned, and people go on to receive many, there are many lines of chemos that people receive, and that speaks to the fact that we are always developing new things. So what is exciting about this paradigm is all of the places we have and continue to make progress. We can do this all along the treatment paradigm. So even prior to diagnosis, we can identify people at increased genetic risk for ovarian cancer and prevent it. In terms of symptoms, we can educate both people at risk for ovarian cancer as well as others about the symptoms, and we can educate healthcare providers in other fields to recognize the symptoms better, basically, advocacy and awareness of ovarian cancer symptoms. And I won't talk much more about this because OCRA does an amazing job at this, and you don't need me to tell you about that. Once somebody is diagnosed, we can make sure, once somebody believes they has ovarian cancer or is diagnosed, they can get the right care from the right doctor at the right institution and get the right treatment plan. They can get the right decision about whether to start with surgery or chemotherapy. Once they start chemotherapy, they can get the right drugs up front and we can cure more patients. The concept of saving drugs for later is really losing traction. Once somebody has responded to frontline therapy, we can give maintenance. And all along the treatment journey, we can select the right drug for the right patient at the right time, and we can improve the lives of people living with disease. So first, let's start with prevention. How did we used to think about ovarian cancer genetics? We used to think it was small amount, 10%, and of those pretty much all were BRCA1 and 2 mutations. Now we know these were all a whole bunch of patients with ovarian cancer who were on clinical trials. Their tumor, they were sequenced, and we actually found that even though still a majority of patients do not have genetic predisposition to cancer, there's a good number of these patients that do have mutations that predispose them to cancer that are not BRCA1 or 2. And what are these mutations? This is a breakdown, and I don't expect you to look at all this, but the important point is that almost a third of patients with mutations that have ovarian cancer have them in non-BRCA genes. And this is part of what has been very important as we learn more about panel testing. So why is testing important? So it's important for you for your treatment, and I'll speak about that momentarily. And it is crucially important for your family, because if you have a mutation, letting other people in your family know is called cascade testing. And for every person that is found to be positive, if they tell other people, this effect can just explode. And if you have these mutations and actually take action based on them, you can truly save lives. So that's extremely important. And one other small comment about genetics before I go on is that the way we do genetics has changed significantly since 2013, when panel testing became very available for people. And if you were tested prior to that, or even prior to a little after that, while people were still accepting the change, I would strongly suggest you talk about getting re-counseled. So the waterfall here is to transition, but also because, again, testing family members of someone with genetic mutation and acting on results literally saves lives. It's a big deal. So once somebody is known to have a mutation predisposing them to ovarian cancer, a very effective way of preventing ovarian cancer is risk-reducing surgery. And we do have general recommendations here. Risk-reducing surgery is generally removing the tube and ovary preventatively. For BRCA1 mutation carriers, we recommend this be done between 35 and 40 years. For BRCA2, between 40 and 45. This puts people into early menopause. And now we are actually also testing a means of what we hope is cancer risk reduction by just removing the tubes for the purpose of for the reasons that I discussed previously, that we actually think a lot of these ovarian cancers arise in the tube. We believe that if we remove the tube preventatively, we can reduce cancer risk without putting people into menopause. And the plan, though, is not only tube, but we call it salpingectomy with delayed oophorectomy. So this is a paradigm that we're currently studying in a very large way for BRCA1 mutation carriers. And I'm putting a plug in here for the SOROC trial, which you can ask your anyone your gynecologic oncologist about, should this be applicable to you. Again, and it's also oral contraceptives that have reduced the risk of ovarian cancer. Another thing that has reduced the risk of ovarian cancer is something called opportunistic salpingectomy. And I mentioned that before, but what this is having your tubes removed when you're doing something else. So instead of tying tubes now, for example, tubes are removed. When people are having a hysterectomy for fibroids, their tubes are removed. And by doing this, remember that most people that have ovarian cancer do not have a genetic predisposition. So by doing this, we're trying to cover the other people, the people that are not removing their tubes or ovaries for preventative reasons because they're known to be at increased risk. So that was prevention. So now let's talk about making sure that people get the best care. In 2013, the New York Times, and I remember this being on the front page, but I don't know that it was when I looked at the actual front page. Denise Grady from the New York Times published this story, big headline, widespread flaws found in ovarian cancer treatment. Ooh, that's a big one. And this was actually, this had been presented at the SGO meeting that year, and it was a big deal. And what this study found, and I won't get into every detail of it, but on a national level, it found that only 1/3 of patients were receiving the best possible care. And that surgeons who operated on 10 or more patients for ovarian cancer and hospitals who had 20 or more surgeries for ovarian cancer per year were more likely to stick to guidelines and those patients were more likely to live longer. And among advanced patients, 10% more were living at 5 years than those with lesser care. So this is a very big deal because 10% more living at 5 years, you know, some of our advances that we make in drugs and all of that might not give us that much. But even if we have the means to make people live longer, we need to get that to all people. So that's an extremely important concept here. So what is the right care? You might have heard before of NCCN guidelines, or these are guidelines put out by the National Comprehensive Cancer Network. And this is basically, it's not a cookbook by any means. It basically gives you some standards. It's a consensus of the authors who are members of NCI designated comprehensive cancer centers across the country. And they review currently accepted approaches to treatment and provide evidence-based care. So we know how to treat. We know how to treat ovarian cancer. We know the best ways. Everybody should be getting that. Super important. So getting the right care from the start is critical. And sometimes it's knowledge, whether it's a knowledge gap, people don't know how important it is to see the right doctor, for example, but a lot of times it's access. And there are areas in this country that don't have access to specialists. They're actually, these maps are showing the distribution of gynecologic oncologists as well as gynecologic cancers. And in this country, there are almost 3,000 counties where there are no gynecologic oncologists. So we need broader access to specialists. We need outreach from rural areas, especially, and we need a universal healthcare system that will also improve our access. So there's my plug, but this is crucially important. So now let's get back to treatment. So for frontline treatment, we have the same standard that we've had a very long time. So you Taxol and carboplatin. What is new here? Well, this is not new, but we know that the vast majority of patients are going to have a complete response to this treatment. What is new here? We have better supportive care, better medicines to treat the side effects of these. We have cold capping, so people may not lose their hair, or may not lose as much as their hair. And we generally have wonderful supportive programs in general. So I think, honestly, it's the same drug, but I think people are living better going through this chemotherapy. So this is the current frontline treatment standard for ovarian cancer. I'm just going to run through this. We mentioned once somebody has ovarian cancer, they should get testing and their tumor should get testing. I'll speak about that a little bit later. The first decision is whether they should get chemotherapy or surgery. Then they go into carboplatin and paclitaxel, which I spoke about before. It is possible that this drug, bevacizumab, that's the anti-angiogenic drug, can be helpful in certain patients. So once a patient starts on treatment, the first decision is whether they should have bevacizumab or no bevacizumab. And then they complete their treatment. And then we get to maintenance. And that's, if you remember, a big paradigm shift for us. But at this point, when one is done with chemotherapy, the question is, should we add a PARP inhibitor? And I'll speak momentarily about that. But these are pills that specifically focus on the inner workings of cells, of your cancer cells, to help keep them away. So if somebody did not get bevacizumab, but was found to have a BRCA mutation or be HRD, and literally I'm speaking about that momentarily, then we know that they should have a PARP inhibitor. And there are phase 3 trials supporting this dramatically. If their tumor does not have either of these features, their tumor, we would say, is homologous recombination proficient, you can do a PARP inhibitor. There's some data for that, or people can be observed. So maintenance may not be for everybody. So this is just a discussion. I'll speak about that. If somebody had bevacizumab during chemotherapy, if they have this HRD situation, you add a PARP to it. If they don't, you continue the bevacizumab. So that's basically now how we think about the frontline treatment of ovarian cancer. So what is HRD? HRD stands for homologous recombination deficiency. And to explain that, I wanted to explain very quickly, I promise, about what homologous recombination is. Basically, what homologous recombination is, it's a way that your cells repair their DNA when there's damages. And this shows a double-strand DNA break and all these proteins coming in to assist with the repair. And you might recognize some of them, such as BRCA1. So you have a mutation in BRCA1, and this whole thing is not going to work as well. So when this works well, we say a tumor is a tumor. We actually sometimes say it's the patient that's homologous recombination proficient, but anyway, it's really sort of the cells in the tumor. If it doesn't work, we say it's homologous recombination deficient. So that's how we use that terminology, HRD, HRP. What is homologous recombination again? It's basically your body's ability to spell check, errors, to fix errors along the way that have happened. So a lot of the genes that we know about that are responsible for ovarian cancer are associated with homologous recombination. And when you put this all together, over 30% of women with ovarian cancer show some form of homologous recombination deficiency. Most of it's genetic, but the rest is somatic in the tissue. And this is really important for treatment. There are different mutations. Again, it's not only BRCA1 and 2 that are responsible for homologous recombination. These are shown here. It's different in the blood, that's germline, than in the tumor, that's somatic. See, it's quite a different distribution of genes. So how are you, or how can somebody be HRD? Again, I don't love that terminology, but you're going to hear it, so I'm going to use it. There are two ways. One is from a blood test, germline mutation. That's your genetic testing that you do to see if you were born with something that made you that way. And the second way is somatic. This is when the tissue is sent to a lab, and this can be evaluated for HRD in two different ways. It can either be checking for mutations. For example, if it has one of the mutations that was on the slide I just showed, then you would say that that patient is HRD. But there also is an HRD score, and that was what was used in a lot of the trials I'll mention soon. And just to speak about how the HRD score is different from the mutation testing, the HRD score potentially picks up more patients because it doesn't only look at mutations, it also looks at things that happen afterwards. This is called methylation or epigenetic changes, as well as unidentified causes. Find more ways that these tumors may be unable to repair DNA. So you will pick up more patients that may benefit who may really also have homologous recombination deficiency by using these scores. So this is still an area that's under, works, but this is very important, and it is an advance. So again, remember, so this is when we talked about the HRD. It will determine whether or not whether or not people get PARP inhibitors or how somebody is counseled for PARP inhibitors. And I'll speak about that momentarily. Now, how did this all start? Okay, this is my second graph. So this was a very dramatic study. So SOLA-1 was a study for BRCA1 and 2, either mutation carriers or people who had the mutations in their tissue. After they finished their frontline chemotherapy, they started on either a PARP inhibitor, olaparib, which is an oral medication that really specifically works at helps with in patients that have HRD tumors, versus being on nothing, because previously really being on nothing was standard of care. And what this found was what we use this word, it was even used prior to COVID. We said unprecedented benefit. And the other interesting thing about this drug is that we found that even when people stopped this drug, because they took this drug for 2 years after they finished their chemotherapy, the benefit persisted. And this is really unusual because a lot of the times when we give drugs for maintenance, the benefit ends when we end the drug. So this data is still new, but basically people with BRCA mutations who took olaparib had essentially a 70% higher chance of going on without progression. So that's a very big deal. And then there were more trials in the frontline setting. And I say these were 4 positive randomized trials. I'm not showing one because it's with a drug that's not available, but these are 2 of them looking at different PARP inhibitors used in the frontline settings in different ways, slightly different populations. But the things that you can see, again, are all of these curves have a lot of space between each other, and they're not meeting each other as things get further on. So there have been a lot of trials showing improvement in progression-free survival, that's time without disease growing in the front line. In addition to the ones we've been talking about for a long time, we recently heard about a trial called PRIME that looked at niraparib, which is another PARP inhibitor, versus placebo in the front line, as well as Athena, which looked at rucaparib versus placebo in the front line. And as well as a study called Ovarian, which, similar to a prior study we had called Paolo, looked at a PARP inhibitor, niraparib there, plus bevacizumab in the front line. And all of these were really, really promising. These three rows show the breakdown of how well they work by whether the tumor was homologous recombination proficient, homologous recombination deficient without a BRCA mutation, or patients that had a BRCA mutation. And you can see that these numbers are really dramatic, but in case you don't really want to look closely, I'm going to go to the bottom two here. So in a BRCA wild type patient that has an HRD tumor, these drugs gave more than a year of time without needing additional therapy. And those with BRCA mutations had at least 2 years, the majority, without needing additional treatment. And most of them have not recurred as yet, as these trials are following up. So this is very dramatic. And this is why we keep using these words, paradigm and unprecedented and all that. Okay, so just going back to the slide, and I promise we'll move on from here. We use biomarkers to figure out the best treatment for somebody. So these biomarkers are far from perfect. And why do we even check them if in all of these studies, and I didn't actually show you all of this, but some of the studies have actually shown that that PARPs are helpful in patients that don't have HRD tumors. So there are certain people, we believe probably around 10% of people that don't have HRD tumors will still respond to PARPs or still do well with PARPs in the maintenance setting. Some of our approvals, specifically those associated with PRIMA and PRIME, are regardless of whether a tumor is HRD or HRP. So why do we even look at these biomarkers? And I still think it's important to look at them because we can use the biomarkers. Are you BRCA positive? Is your tumor HRD? Is your tumor homologous recombination proficient? To help make decisions. We can sort of give a better idea of how much that maintenance therapy will help. And by doing that, patients and their healthcare team can make decisions to figure out if maintenance is the right thing. I've been saying maintenance is like the holy grail, but I do want to talk about maintenance for 1 second. So if you want to think about it, how we basically have something similar to what breast cancer does with its tamoxifen and aromatase inhibitors, although ours is not hormonal, so don't think of it that way. This is not a magic pill. There are side effects that go along with it. It is expensive. There are other things about this. But when you think about maintenance, the goal is to maintain a response. So you have to have something that worked already, and it's generally pretty long-term. It's really important, and I try to explain this to patients a lot, because when you're going through your frontline treatment, people will take literally any side effect if they think you're going to do better. But once you're done with that treatment, you really have to think about your quality of life. And ideally, a maintenance treatment would not mess that up too badly. And we really don't know how to best judge efficacy here. And it's very complex. Again, probably a discussion for another day. So our treatment paradigm, we've gone through our frontline treatment, we've had our maintenance. What happens next? So this right-hand side of the slide is showing what happens. Yes, there are people that are going to be cured after that maintenance. And we hope that we are underestimating this. There may be more and more. So some people will be cured. Unfortunately, a majority will not be cured. And these patients will go on to additional lines of treatment, possibly with maintenance after them. So once somebody does recur, and again, some people are not going to recur, but the reality is that many do. And even though a complete response is possible with recurrent ovarian cancer after treatment, most of the time, what we know about recurrence is that traditionally, if you've recurred once, you are most likely to recur again, and that the intervals between recurrence get shorter and shorter. We also know that your fifth line treatment is not likely to work as well as your second line treatment. But by using maintenance in here, we are hoping to prolong the time between different lines of therapy. So I wanted to just step to the side. How do you decide between what to do when you have recurrent cancer? There's really no single best treatment option for people with recurrent ovarian cancer. There are reasons why one may be better for you than another based on how your tumor is or something like that. But in general, you cannot say there is one treatment that is best for all people with recurrent ovarian cancer. There are different side effects. You have to think about maintenance. Do you want that? Do you not? The choice of treatment really needs to be made by patients working with their healthcare team, shared decision making. So we talked about maintenance previously. There is maintenance in the second line and further. This slide is a pool of studies that looked at PARP inhibitors as maintenance for recurrent platinum-sensitive ovarian cancer, meaning that if your cancer came back and you had some, more than 6 months from your last platinum, and you had a chemo regimen that included platinum, you might go on one of these drugs. So all of these looked at either going on a PARP inhibitor versus no further treatment, which was the standard of care. And there was really, really excellent data here. We showed improvement in survival, in progression-free survival. And this was done for different groups. Solo 2 was for patients that had BRCA mutations. This shows a pretty dramatic difference in progression-free survival. Study 19 was for all comers. Very, nice difference here. Nova looked at niraparib, again, very similar numbers to Solo 2. And then there were, in niraparib, also showed a dramatic difference in progression-free survival for those without BRCA mutations, as did Ariel. And what this led to is us using PARPs for maintenance in the after progression. But what do you do for somebody who already had a PARP earlier on? This study called Oreo, last graph, it actually showed that you could use PARP again for maintenance, even in people that had previously had PARPs. And actually, interestingly, in this cohort, it didn't matter if your tumor was HRD or not, but there was still some benefit that was shown. Now, there's statistic benefit and there's clinical benefit. This did show an improvement statistically in time. It's not a ton of time. Again, statistics are one thing, clinical benefit is another, but olaparib still may help. You can re-challenge with olaparib and show an improvement in PFS versus placebo, regardless of BRCA or HRD status. So we want to make this journey as long as wonderful as possible. So we've been focused on HRD and PARP because it's a big success story. But let's say you're not in a state to be maintained. So to go on maintenance, you have to have something that worked to some degree, at least kept your disease from growing. But what are options for people that maybe don't have HRD tumors or have disease that hasn't responded to prior things? So for people that do have BRCA mutations, even PARPs can be used not only for maintenance, but for treatment. And this is how they actually started out. And there was a lot of data looking at that. So for people that do not necessarily have HRD tumors, combining PARP inhibitors with other drugs may be the way to do it. And this study was called Topaccio, and which I like, but it is a combination of niraparib, a PARP inhibitor, plus pembrolizumab, an immunotherapy agent. And this was used in people with recurrent ovarian cancer. And what I would like to show you here, this is called a waterfall plot. These things going down are tumor shrinking. And this one is called a swimmer's plot. And this is how long this effect lasted. This was a very exciting trial in general, and it worked especially well for non-homologous recombination disease. Now, unfortunately, immunotherapy alone has been a bit disappointing in ovarian cancer. And I really hate to use that word, but we found that ovarian cancer is not necessarily as hot or immunogenic as we may have hoped. So again, using it, this is one way to use it in a combination with a PARP inhibitor. And there are other combinations using immunotherapy with different drugs. And this is one that I like specifically. But this is a regimen using pembrolizumab, which is immunotherapy, plus bevacizumab. You heard me mention that before. That's an angiogenic, with oral metronomic cyclophosphamide. This is Cytoxan, a small dose. It's a chemo in a pill. It doesn't really have the side effects that other chemos have. But this was a very exciting trial because, again, this is that waterfall plot, shrinking tumors, a lot of them all to this side, with this combination. And I should say that this combination does not have the side effects that you're used to with chemotherapy. So this is a very well-tolerated regimen as well, as is the one prior. So basically you can combine PARPs with different agents. You can combine immunotherapies with different agents. What else is there? The other sort of exciting, and there's more than what I'm going to mention, but I'm mentioning a couple of things that are exciting. So antibody drug conjugates are another class of drugs that we found to be very exciting. So basically, these all look like little Ys. I think I'll explain that momentarily. But what happens with the antibody drug conjugates, or ADCs as we call them, is they deliver something really, really potent directly to the tumor. They use the antibody to basically, it gets attracted to the tumor and kind of gulps it in. While it's gulped in there, the very potent chemotherapy, I'm going to call it the very potent, I don't know what to call it, killer stuff, is released and so basically you're able to give something that's very, very strong. If you gave this, just IV and it worked in all your cells, it would be too toxic for you. But by doing it this way, you could deliver something very strong and giving without quite the toxicity. A lot of us hope that this could replace chemo in the future. So ADCs have three parts. There's the antibody, and this part is highly selective to a specific target on tumor cells, and there are different ones that are used. This is called the payload. This is the potent cytotoxic agent that causes cell death when internalized into a cell and released. Again, these are very, very, very toxic. So something like, if you would think maybe if we have something that works so well, why not give it to everybody? But you need to do it in this way, because if it were allowed to go free throughout the body, it's too toxic. And the linker, this part is something that's stable in circulation, meaning that it keeps the payload, on our little Y, but it releases it when it needs to. And two of there are more ADCs than this, but two of the most exciting ones I'm just going to mention here. One is called mirvetuximab. I know it's a mouthful, but this is a drug that's been studied extensively. Its antibody is the folate receptor alpha. So we have learned that for tumors that overexpress this, that have a lot of that folate receptor alpha, this drug may work really, really well. And this has been looked at in very, very heavily pretreated patients, and about a third of them had a response that lasted 6 months and very little toxicity. And this is another ADC that I found to be that I'm very excited about. It's called dolaflexin, and its antibody is NaPi2b, which is more common. You don't actually at this point, I believe, test for that. But look at this nice water plot. Giving this is also shrinking tumors. And both of these are continued to be used in trial settings, and hopefully you'll be learning more about these in the very near future. So how did all of this happen? How did we make all these advances? And I didn't even speak about all of them. There are more. I'm sure if you're listening to other talks, you will hear about them. But we made I wrote clinical trails. It's not a clinical trail, it's a clinical trial. It is clinical trials is how we made all of this advancement. And there's always a bit of uncertainty about clinical trials, and there's bias on all sides. Some providers don't offer them, some patients don't want them. But I would just stress to you that it is really the best way to move this forward. And importantly, I want to thank anyone on here that has been on a clinical trial or who has thought to go on a clinical trial, because that is why things are so different now than they were 20 years ago. What is a clinical trial? It's the process through which standards of care are defined, and it's the key to improving prevention, diagnosis, and safe and effective cancer treatment. And clinical trials can be treatment. They can be looking at blood or tissue. Those can help you figure out the science behind endometrial cancer. It can be a quality of life trial, questionnaires, prevention, and it can be something where you're just observed. But this is how the medical, the state of medicine moves forward through these clinical trials. And this is how the care for people with ovarian cancer improves as we work towards a world without ovarian cancer. I so thank you for this opportunity. I hope it was clear. If it's not, please just email me or find me on Twitter and let me know, because I think the message is clear. We've made so much progress, and it's really thanks to a lot of people like you who have supported research, who have advocated, and who have participated on clinical trials. Thank you.